Good morning, everyone. My name is Robert Libbey. I'm a registered massage therapist, author, clinician, and researcher. Thank you so much for being here with me today. Thank you to the American Massage Therapy Association and the Massage Therapy Foundation for funding these research poster sessions at the National Convention here in Denver. Today we're going to be going through the research on arthrotomes, joint capsuloligamentous tissues mainly supplied by afferent nerve fibers from the dorsal roots of any given spinal nerves, mapping joint capsuloligamentous innervations for pain, proprioception, and rehabilitation, a clinical framework for organizing the segmental afferent innervations of joint capsules, ligaments, bursa, and related articular tissues. All of this research is documented in a book that I published recently called Ligament Pain, your resource for axial and appendicular ligament and joint tissue referral patterns. You can scan this QR code to be taken to the web link where you can purchase the book. This project started with a simple question. Clinicians are very familiar with dermatomes and myotomes. Dermatomes help us organize sensory information from the skin. Myotomes help us think about muscles and movements. But what about the sensory innervation of joints, ligaments, and joint capsules? This information exists, but it is scattered across anatomy, neurophysiology, and clinical literature. It is rarely organized in a way that is easy for us to use in clinical reasoning. This review proposes the term arthrotome as a descriptive framework for that missing piece. In simple terms, an arthrotome organizes the sensory or afferent nerve input coming from joint capsules, ligaments, and related articular tissues by spinal nerve segments. Why does this matter? Ligaments and joint capsules are not just passive straps that hold joints together. They contain sensory nerve fibers that contribute to nociception, meaning signals related to potential or actual tissue threat, proprioception, our sense of joint position and movement, and sensory motor control, the way sensory information helps shape muscle activity and movement. This study used a two-phase literature review. Anatomy and neurophysiological textbooks were screened, followed by electronic searches of the research literature. The findings were organized into a central database by spinal nerve segment, peripheral nerve, joint or ligament, and source reference. The main finding is that joint capsuloligamentous tissues show identifiable segmental sensory contributions. Many joints receive input from more than one spinal segment rather than from a single isolated nerve root. So arthrotome mapping may complement dermatomes and myotomes by adding a joint-based sensory framework. Clinically, this may help us think more clearly about joint-related pain, referred symptoms, altered proprioception, changes in sensory motor control, neurological and orthopedic assessment, and rehabilitation after injury or surgery. One practical question is this: is this muscle truly weak, or is altered afferent input from the injured joint inhibiting normal activation? A good example is the quadriceps after an ACL injury or reconstruction. A person may be trying very hard to contract the muscles, yet altered sensory input from the injured joint may contribute to persistent inhibition. For massage therapists, this framework may also encourage a more cautious interpretation of the protective muscle tone. When joint or ligamentous tissues are sensitized, aggressive stretching, deep pressure, or end-range loading may not always produce the intended response. In some cases, this may temporarily increase protective or stabilizing muscle tone. That does not mean massage therapists are diagnosing arthrotomes. It means this information may support clinical reasoning and encourage graded treatment, comfortable positioning, gentle desensitization, active movement, proprioceptive cueing, and appropriate referral for interdisciplinary rehabilitation when needed. There are important limitations. The evidence varies by region and tissue, and some innervation descriptions are much more detailed than others. Arthrotome mapping is a developing descriptive framework, not a universally accepted clinical system, and further validation is required. The main takeaway is simple. Ligaments and joint capsules are not simply collagen structures. They are also sensory tissues. Injury may therefore involve both the tissue and the sensory motor system. Please scan the QR code on the poster for the Arthrotome database, references, and supplemental material. This information has been documented in great detail in my textbook on ligament pain. You can scan this QR code to be taken to the website where you can purchase your copy. Thank you again for being here with me today at the American Massage Therapy Association National Conference. Thank you also to the Massage Therapy Foundation for sponsoring these research posters. I greatly appreciate the time and effort that everyone has taken to peer review this information, and for you specifically for being here, being interested in this information, and being interested in research and incorporating this into your clinical practice. Thanks again.